the optimal position. The ideal position is sitting, not supine or prone. However, I will say this, whenever we are measuring a patient's inversion or anteversion or retroversion, we actually do the measurement prone. Just as a little tidbit for you to look forward to in ortho. But, so where do you think what are our normals for internal rotation?
30 to 45.
30 to 45. What about external rotation? Flip the page, Ellen.
32 to 50.
32 to 50, or 30 to 50, I think is what we kind of just made it a little bit bigger. Okay, what does, you don't move, what does internal rotation look like?
Her foot will go that way. Out.
Her foot will go out.
She's got this option or she's got this option. Does everybody agree in this for internal rotation?
You're turning
That
in.
is terrible.
It sure is.
You danced. Okay, internal rotation, the foot is going out. Because what's happening at the hip?
The hip.
It's going like that. Okay, it's rotating in. So don't be thrown off by the fact that the foot comes out for internal rotation because the hip is going in. Okay. For external rotation, then it's gonna go 180 degrees. We're gonna bring that foot in, okay? Because again, we're talking about the hip, and it's doing that motion. Where's our fulcrum gonna be? It's the same for both
Where the
motions.
foot, or the
Say it loud, Maka.
The aspect of the patella?
The aspect of the patella, or the
Anterior aspect.
there we go. The anterior aspect of the patella. So essentially, right there. You can imagine it as if we were to draw a line straight down the femur, and it pokes out the end of the knee. It'd go through right about there at the patella. Okay, that's going to be our fulcrum. Our proximal arm is going to be lined up.
with the other patella.
Perpendicular to the floor.
Perpendicular to the floor, or parallel to something that we can line up with. Okay, so in this case, I could say parallel to the table leg, or perpendicular to the floor, however I want to look at it. Okay, and then my proximal arm, or my distal arm, or my movable arm is going to line up with the tibia. Okay. Down the tibia, and if we want to, we can just go right in between the medial and the lateral malleoli. Okay? Now, just like ab and adduction of the hip, it doesn't necessarily matter if we start, and you'll find this to be common, as far as our starting position, it doesn't have to be right at zero. So if I'm coming up here like that, and I get all lined up, and say she's just in a resting position in slight external rotation, I don't have to be like, no, you start here, and then do the motion, okay? I just know that my documentation and the only numbers that matter are the ones that once I get to that zero and start passing it, okay? So, let's do the measurement. Well, first, actively, let's do internal rotation. I just want you to lift your leg up side. There we go. Good. And now I'm going to take her passively. That's about as far as she gets. Okay. What kind of end feel would be considered normal with internal, external rotation? Okay, so soft tissue stretch, also known as firm. If we want to get really specific, capsular. Okay? Because it's the capsule that's typically tight or that's stopping that motion. Okay? So, you lined up here. And let's say, what?
18.
18, is that what you're saying? Okay. So we want to do some internal rotation. So I can grab her leg, keep that proximal arm perpendicular, up, down, and that's seriously as far as I'm getting. Right there. That is terrible. But at the same time, kind of what I would expect for a dancer.
How come?
We're all about it.
Because they all do external rotation. Ooh, great. Let's see if we can.
Just
right there.
Make sure
That's really.
your perpendicular line isn't quite perpendicular.
Oh, you're right.
You would.
There's 18.
There we go.
Oh!
You took me a little too far. 20.
Ugh.
We got 20 degrees of internal rotation, okay? Now,